Now we'll have with us Professor Romeu Mendes, who is a public health physician, holds a PhD in sports science, and is a researcher at the Public Health Institute of the University of Porto. He's also the Deputy Director of the National Program for the Promotion of Physical Activity of the General Directorate of Health, and the coordinator of the Intersectoral Commission for the Promotion of Physical Activity. He's also the Director General of a community exercise program for people with type 2 diabetes, Diabetes em Movimento, and consultant to the World Health Organization for Physical Activity. Please.
Well, good afternoon. First of all, let me thank the invitation. A special thank to my friend Elisa Marques. It's an honor to be here among such prestigious colleagues. I'm gonna do a very simple thing today. During the pandemic, I have been working on storytelling skills. So I'm gonna use this conference to train my skills on telling you a little bit of a story that is going to be based around not only Diabetes em Movimento, but around the building and the construction, the design and implementation of community-based lifestyle intervention for type 2 diabetes. The storytelling sometimes is a little bit confusing as a method to present science, and I'm not very good at it. I'm still training. Sometimes it gets like a soap opera because I get lost, I get excited, and I get lost on the details. So I ask you please to be focused on stories and on all the parallel stories that I'm going to try to tell you in around 20 minutes. I have to confirm my time, sorry, because I get lost a little bit on time. I'm going to share my screen. Okay. You can see my screen, right? Elisa, right? Okay. Good. So, as I told you before, my presentation is around community-based lifestyle intervention programs. We know that when we look to the clinical treatment and approach, both on primary health care and both on hospital care in Portugal, and the problem is not only in Portugal, it's worldwide. We are too much focused on medication, on drugs, on pharmacological treatment, and we not always have the opportunities. I'm not talking about knowledge. We not always have the opportunities and the motivation for the patients to engage in nutrition and physical activity programs. Regarding physical activity, that is my main interest, as Nuno Jacinto just told you before. When you look to the algorithm of approaching type 2 diabetes, especially hyperglycemia, weight control, nutrition, education, physical activity, they are the basis of the algorithm to treatment of type 2 diabetes. So this is the first step that every clinical or every health professional should start when they want to approach a chronic metabolic disease, serious disease like type 2 diabetes. So what we know from science, we know that lifestyle intervention is as much as powerful like metformin or sulfonylurea. We know that the benefits are broad because we can control diabetes. At the same time, we can improve sleep quality, reduce depression, anxiety. We can reduce the risk of other diseases on patients with type 2 diabetes, and we can even do false prevention with these patients. But there is always a but. 1 year from the start of the health professional's first intervention, 1 year passed, more than 99% of the patients are not engaged in lifestyle change. And this is because patients don't want to change. Changing is a very, very difficult issue. It requires opportunities to change. It requires psychology, behavioral change, theories, and professionals, and it also requires that someone has to start the process in order to the patients to change their behavior. Regarding physical activity levels, one of my first studies as a medical doctor on this field was to assess. Sorry, I have some slides in Portuguese. I apologize for Marina. I'm working on COVID almost 100%, so I don't have all the time I wanted to prepare this presentation. So this is the type 2 diabetes patients in Portugal that were reporting to do exercise or physical activity. And 41% reported, yes, Dr. Romeu, I'm engaged in physical activity. But when we cross the physical activity minimum dose with the reporting exercise programs that were involved, only 1% of the patients were engaged on a minimum physical activity dosage recommended by international scientific organizations to treat and control type 2 diabetes. And one of the faults is a technical fault, because interpreting guidelines, I didn't learn it on my med school, okay? It's complex to understand all the technical terms that are on international guidelines, because there is a minimum dose for aerobic exercise, 150 minutes of moderate intensity per week. There is a minimum dose of resistance exercise, strength training. There is a minimum dose of flexibility. If the patients are elderly, they have to accumulate a minimum dose of agility and balance exercise. And at the same time, they have to reduce sedentary behavior, because it seems there is, at least to some extent, an independent risk factor to all cause of mortality. And also because patients with type 2 diabetes, they have a very specific age, anthropometric, and comorbidity profile. And we don't have to invent the wheel. This WHO report has almost 20 years, and it states very well what works: community-based exercise interventions for homogeneous groups of patients. So we need to change the paradigm a little bit. I know that my clinical medical specialties colleagues, they like the word, I also like the word precision medicine. And we have to change the paradigm from the public health perspective. I'm a public health medical doctor. We have to work with something that I like to call public health by design. We have to design interventions in order to achieve better health outcomes in our communities. And we decided that we wanted to design a program that it was feasible, acceptable for the population, clinical effective at low cost, safe, with prevention of adverse events. And to be clinically effective and to be safe, it should be with supervised activities. And in 2009, it was born the Diabetes em Movimento, in English for Marina, the Diabetes in Motion exercise program. So Diabetes em Movimento is a community-based exercise program for people with type 2 diabetes, both genders, between 50 to 80 years old. Nowadays, it's the biggest community-based exercise program run by a health institution, a public health institution in Portugal. It is actually run by the Director General of Health for the National Program for the Promotion of Physical Activity. So why it is a community program? Because it's free to the patients, but someone has to pay. Someone has to offer the resources. Okay, so it is a mix, a combination of several institutions. They can be different on every community, but mainly they involve primary healthcare institutions, they involve municipalities, they have the sports resources that we need with hospitals and universities. And me personally, I like the concept of exercise is medicine. And in Portugal, we use incorrect translation of this concept, because medicine is the drug, is exercise as a drug, exercise as a pharmacological treatment. It must be efficacy, effectiveness, keywords, safety, feasibility, acceptability. So we designed this program and we tested it as we should test a vaccine or a medication, a new medication at some extent. And we wanted to do a polypill exercise session. On the same session, we wanted different types of exercise as the ones I showed you before on the international recommendations for the treatment of type 2 diabetes with physical activity. So every time the patient goes to an exercise session, we gave them aerobic exercise, flexibility, agility, and balance, and also muscle and bone strengthening exercises. So the program started, the laboratory started in 2009 in Covilhã. I studied medicine and I did part of my PhD in University of Interior in Covilhã. Although my PhD it was in University of Monteceltor, where I live and I lecture in nowadays, and 2 years of laboratory works, individual testing of each exercise that we wanted to implement on this field work. On 2011, we used it, the community, the physical activity community infrastructures to implement our community-based exercise program with always the key word, low cost, low cost, low cost. So here it is, our exercise session structure, like a poly pill with different types of exercise. Every time the patient comes to the program, that is 3 times per week, because 2 times per week, it is not enough to accomplish with a minimum dose recommended for type 2 diabetes treatment. So the patients have aerobic exercise, they have muscle strengthening exercise, they have balance and agility exercise, they have flexibility exercise, and we have a special care on the prevention of acute adverse events, because they have diabetic foot, because they have cardiovascular risk, because they fall a lot, because they have kidney problem, they have eyes problem, they have a lot of comorbidities, they have the potential to have exercise-related injuries or acute adverse events. So we assess on every session was acute glycemic control. We try to assess blood pressure. We assess food state. We assess exercise intensity at each exercise session at different moments. And we try to have always a little individualized feedback, especially from the biomechanical and the postural point of view to each patient, because this is not an individual program, it is a community-based exercise program, as you know. We did this is all about science. We registered a clinical trial. We were not able to do a randomized control trial. We did only a controlled trial, and we compared usual care with usual care plus the exercise program during 9 months. We published a lot on these papers. Just to tell you that the first study that we did, it was around the effects on physical fitness. Everything improved. We didn't invent the wheel. We were not testing the exercise itself. We were testing a special way, a special method of giving a specific dose of exercise or physical activity to patients. And as we were expecting, all the clinical variables that we tested, mainly glycate hemoglobin, they also improved. We won with this clinical study. We won the award in Roma. It was like the National Diabetes Award in 2015. Professor Tumuzo Barata was my PhD supervisor, that he was in Lisbon to receive this award, and the project ended. We wanted to test the efficacy, not the effectiveness, because we did a per protocol analysis and not an intention to treat analysis. It was per protocol. So we did an efficacy analysis. So if people come to the program, if they take the pill, type 2 diabetes in all the cardiovascular risk factors, they will improve. The project came to an end in 2013, and then I changed my life to Vila Real, where I live now, where I'm now at my home doing this presentation. And for the first time, we decided to implement the project, but not as a scientific project, but like a true community-based exercise program. So we use it exactly the same methods, the same philosophy of the program that we tested before. So we use the infrastructures that were on the community, the same low-cost materials, the same exercise sessions, and we started to think on how to scale up. And we started to receive a great attention, mainly because we won Diabetes National Award, and we started to receive many emails and phone calls, and we were waiting that this was the first question. How much it costs? And it's cheap. Cheap? What is cheap for you? How much cheap? Did you did an economic analysis? At least a costs analysis? No, we didn't. So our first step was to do this economic analysis. So we did a direct cost analysis from the healthcare perspective. Okay, we did it for 2 groups of 30 individuals during 9 months, 3 sessions per week. We calculated everything that you could even imagine, and this was the result. This is a really, 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 really low cost intervention because it costs less than most of the community-based exercise programs that municipalities offer to people, to patients, 2 times per week. And we are offering a program 3 times per week with an exercise professional and a nurse full-time on every session and during the whole program. The next question, and this question was my colleagues from primary healthcare, and also the internal medicine specialists, as someone said before, that in Portugal, type 2 diabetes is mainly treated by primary healthcare medical doctors and internal medicine specialists. The question was, what about adverse events? Do you have collateral damage? What about diabetic foot? What about cardiovascular risk? What about falls? What about hypoglycemia? What about hyperglycemia? What about hypertension crisis? We had the results from one season, 9 months, but we started to calculate the incidence and the prevalence of 3 years, 3 seasons of adverse events, and we also publish it. And you can see that our major adverse events are not diabetes related because we control capillary blood glucose, we control the foot impact, and we control the acute blood pressure. The main adverse events are seizures and falls. At the same time, at the end of the season, we did a picnic. And on this picnic, I wanted to show my students why patients with diabetes, type 2 diabetes, they have a special food and nutrition profile. So this was diet, weight loss, weight management were forbidden words for this picnic. So we asked them to eat freely, to bring freely the things that they naturally bring to a family picnic. I cannot describe you, I knew that. But one of my students that now is a PhD working in Viseu, Carlos Vasconcelos, one of my students at the end of the picnic, he came to me and he told me, "Oh my God, Professor, they eat so much. They brought a piglet. Professor, I saw 4 men ate an old piglet. They brought wine. They brought fortified wine, we call Porto wine. They brought everything that we can imagine that we have at our Sundays lunchtime with our family." And he also told me, "Teacher, they don't know the difference between a fast and a long-acting carbohydrate. They don't know the difference between a protein, a fiber, and fat. They don't know what are micronutrients and macronutrients. They cannot relate, by talking with them, they cannot relate how eating different types of micro and macronutrients we can increase or decrease the risk of several diseases. And this conversation, this insight that I have with my student, now a PhD, we decided that we wanted to go for a second clinical project. And this project was about testing how to include a food education program into the community-based exercise program. So we registered a second clinical trial, this time because we had several schedules and several groups of exercise. We could randomize. So we tested usual care plus exercise program versus usual care plus exercise program plus a food education program. We assessed food education with a questionnaire. I'm not going to give you much detail. So the food education was very simple. It was composed of 15 minutes lectures on an auditorium room, and then we integrated the traffic light method to do health literacy and health education. So we presented that many challenges, and they just had to highlight which color that food was under in order to give them some health literacy. They were taught to interpret food labels, to discuss food labels individually with colleagues or at group. And we run these scientific projects during 2 years. This is the soap opera part. At the same time, on 2016, we decided to go for national expansion. So we first expanded to 3 cities. It was like a university expansion, very simple. We went to the place, we did training to the people in the place, and everything went well. The next season, we decided to expand to a little bit more cities. So we have to do a national training. We have to publish a manual, a technical manual, in order to people to understand all the details that are around implementing this community-based exercise program. And then on 2018, the program was invited to be managed by the Portuguese Director General of Health. And we had the opportunity to reach much more cities, much more municipalities, and much more patients with type 2 diabetes. We had to increase our training capacity. And then in 2018, on the first year under the Portuguese Director General of Health, we had the first results from this project. And just to resume the results, yes, they have major gaps on nutrition-related knowledge. Yes, the 15-minute lecture, 16 weeks, was able to increase their nutrition-related knowledge. The knowledge gave them capacity to change their dietary pattern. And when you change your dietary pattern, you get better outcomes rather only engaging on an exercise program. And the consequence was that on the next expansion, 2019-2020, from 32 municipalities, around 1,500 patients that we had when COVID came, we established some health education session mandatory, at least with some mandatory topics. Sorry for the big Portuguese, Marina. So we used the 15-minute lectures in some complementary way with some field work, as a photo that you are seeing here. This was a session we invited a cooker in order to teach the patients to cook in a healthy way. I need more 2 minutes. Sorry for the late. I had to fulfill the soap opera. Elisa, it's okay, 2 minutes more? Okay. So parallelly, on 2017, the Portuguese Football Federation was trying to improve the concept of the football is medicine. It's a worldwide project funded by FIFA and by UEFA. And the concept is play football for health. And one of the methods that we can use to put people, older people, fragile people playing football is using walking football. And we did it. We designed we used again public health on design. We designed the SWEET football project. SWEET is for diabetes, I know, but it means safe, wholesome, and effective exercise training. We did a feasibility and safety study. We engaged a primary healthcare center in Porto, o Centro de Paranhos Primary Healthcare, and this primary healthcare, 200 meters, they have a soccer field. So we recruited, with the help of the primary health medical doctors, they recruited 2 teams of 20 patients. And 3 times per week, 60 minutes, with the help of a football coach, of exercise physiologist, and a sports nurse, we put these people playing football, indoor, outdoor. This program has a very strong social and emotional relation because it's just for men. Just for men, they all love football. They are all elderly. They all have diabetes. So they are like a family and they like to dress the same t-shirts. Okay, the results are all published. And we started to think on how to scale up, not through the Director General of Health, because we wanted to scale up through sports clubs, through football clubs. And then COVID came. So because diabetic patients are at risk of severity of COVID outcomes, so we started to, some municipalities from Diabetes in Movimento, they were able to do Facebook classes, some we used Zoom, some used Teams, some people were able to maintain with a manual the same structure at their homes, but the truth is that we want the future back. I don't know what is going to be the future of these community-based exercise programs, because people like to touch each other, people like to get together, people like to change materials, to change like a soccer ball, and there is a huge thought around what is going to happen to this type of community exercise or nutrition programs in the future. Thank you.